everyone. My name is Claudia Frankfurter. It's a pleasure to be here at the St. Michael's Hospital Echocardiography Lab rounds. And today we're going to go through a comprehensive transthoracic echocardiogram. So no disclosures. Today we're going to review the standard image acquisition sequence and optimization strategies for transthoracic echocardiogram. We're going to highlight some accurate measurement techniques and chamber quantification guidelines, and we're going to discuss echocardiographic findings of common cardiac pathologies. So this will hopefully be a valuable resource for novices in echocardiography and a worthwhile review for the seasoned experts in the audience. We're going to start off with some words of wisdom from the father of modern echocardiography, Dr. Feigenbaum, 1996. He said that humans have known that creatures with wings could fly. Since nature did not endow humans with wings, we had to build machines with wings so that we could fly like birds. In many ways, we are doing the same thing with diagnostic ultrasound. Nature did not see fit to give us sonic imaging capability, so we must build appropriate machines so that we can visualize ultrasonically as other mammals do naturally. These are two seminal documents that are going to form the basis of the talk today. From 2015, the Chamber Quantification Guidelines by Dr. Roberto Lang and colleagues, and from 2019, from Dr. Carol Mitchell on the comprehensive transthoracic echocardiogram. So echocardiography has come a long, long way, and what started off as a simple M mode going into some mitral stenosis has since evolved into a very complex and comprehensive protocol that we're going to hopefully break down today. So there are 4 standard transducer positions and 2 patient positions that we're going to review. We're basically going to think of the heart along different scanning planes. So when we look at the long axis plane, going from the superior to inferior part of the heart, that really forms the basis of the parasternal long axis view. When we look at the short axis plane, that is sort of cutting the heart into slices and is akin to the parasternal short axis view. And likewise, along the apical plane, naturally forms our apical view. So when we start off with the parasternal long axis, the patient is in the left lateral decubitus. We place the transducer in the 3rd to 4th intercostal space in the left parasternal area, and we get images along both the long and short axis of the heart. To get an apical view, the patient remains in the left lateral decubitus position, and we put the transducer at the maximum impulse, sometimes helpful to feel where it is manually, but we can move more laterally and lower down if needed. And we help sometimes time with inspiration and expiration based on the views. The subcostal view is obtained with the patient in the supine position. Sometimes we get the patient to bend their knees. It helps relax the abdominal muscles and to take a deep breath as it helps lower the diaphragm. The suprasternal view has the head extended and a little bit leftward, and the probe is placed in the parasternal notch. Now, this is a very valuable acquisition sequences that has been imparted to me, and this is a common criterion used by accreditation bodies. So whenever obtaining images, it is really helpful to think of the 2D color and Doppler sequence. So we start off with a sort of typical grayscale 2D image, followed by the color applied on top and Doppler. And this helps facilitate interpretation at the end. The timing of the acquisition of various images is important, and best to define perhaps now that end diastole is the frame in the cardiac cycle in which the cardiac dimension is the largest. This is the most commonly used and perhaps more reliable. Sometimes, if the images are not perhaps too clear, you can time based on the ECG, the onset of the QRS, and you can potentially look at the mitral valve closure as well. End systole is the frame in which the cardiac cycle is the cardiac dimension is the smallest, timed generally around the end of the T wave, or the frame preceding the mitral valve opening. So here we are. We're starting off our transthoracic echocardiogram. The patient is in a left lateral decubitus. We're getting our nice first scout view with increased depth. The LV is ideally perpendicular. We don't see the apex, and we're looking really beyond the posterior wall of the heart at this point. Are we looking for pericardial effusions? That would be between the heart and the descending aorta, as well as some pleural effusions that are more posterior and lateral to the aorta, and we obtain a standard 2D clip. We then reduce our depth, and we get a nice viewed image of the parasternal long axis. We are again perpendicular to the left ventricle, and we want to see both the aortic valve leaflets and the mitral valve leaflets move in a 2D clip. This shows us sort of the gross anatomy of exactly what we're looking at. So we have the right ventricle, we have our interventricular septum, we have the anteroseptal wall of the left ventricle, and the infralateral wall, or what was usually in the past referred to as the posterior wall, but the nomenclature has since evolved to help match other cardiac imaging modalities. And we have the mitral valve nicely positioned there, the aortic valve, and the left atrium. When measuring the LV size, we're going to start off by looking at the dimensions. So the left ventricular internal diameter in end diastole is naturally taken end diastole when the heart is at its largest. We're going inner edge to inner edge between the compacted myocardium of the segment and the infralateral wall, and should be just below the leaflet tips, and again, perpendicular to the LV. And we obtain a similar measurement at the end of systole. To look at the wall thickness, we remain in end diastole, and we're looking at that compacted septum. So we try not to include too much trabeculation of the right ventricle, the insertion of the moderator band, or the tricuspid valve annulus. And to get the posterior wall measurement, we try not to include the mitral valve apparatus in the measurement. Sometimes it's important to think about our axis. This is an example here where we have used biplane imaging to show us that when we think, if, for example, here we are actually on axis and taking a good measurement here on the lower quadrant image, when you look at on the biplane to the right, you actually see we're quite far off from the center. So trying as best to optimize our position to get the best dimensions. When we have proximal septal thickening, can pose a bit of an issue of exactly where to measure, and this is a source of healthy conversation amongst the cardiologists and sonographers. And basically, sometimes you can get some isolated thickening of the basal septum. The guidelines will say to measure beyond the bulge towards the LV apex to avoid overestimating the mass. Otherwise, you would assume the whole left ventricle is hypertrophied, akin to what you see in the bulge. And there are variations of this. Some will measure including the bulge, etc., but make some other adjustments. So needless to say, the guidelines outline measuring beyond the bulge. When we assess the LV mass and thickness, this is a very helpful square that you will see in all common reading rooms across, hopefully, North America. And basically, if you have a normal LV mass, a normal geography, great. If your wall thickness is greater than 0.42, we call it concentric remodeling. If, let's say, the wall thickness is normal, but the mass is high, we call it eccentric hypertrophy. And if both the mass and thickness is elevated, we call it concentric hypertrophy. These are a few examples. We have severe concentric hypertrophy here, secondary to some severe aortic stenosis, as you can see the calcified aortic valve, and then some thickening of the left ventricle. Likewise, a similar case of hypertrophic cardiomyopathy with some severe concentric hypertrophy. When measuring the left atrium, it's an anterior-posterior measurement. It's done in end systole. It's inner to inner edge in the 2D, not to be confused to the leading edge to leading edge method for M mode. And you start at the sinus of Valsalva of the aortic root, and you draw a line perpendicular to the left atrium at the bottom there. Normal dimensions around less than 4, but to be honest, this measurement is fading out of practice as we prefer left atrial volumes. Now we move on to our beautiful aortic valve. We slide slightly towards the sinotubular junction. The axis may be a little bit different than the left ventricle. We're trying to stay as perpendicular as possible, and we obtain a 2D and a color clip. In terms of the anatomy, the more higher cusp is the right coronary cusp, and the lower one is the non-coronary cusp on most standard aortic valves. And that the naming is relative to the ostia of the right and left coronary arteries. Some examples here, you may see a bicuspid valve. You see a slightly asymmetric closure line. You get some systolic doming and some diastolic prolapse of the cusps. Here's a common aortic stenosis valve, where you get some thickening and calcification of the leaflets. When doing the measurements, anything basically on the aortic side is measured leading edge to leading edge, and this helps sort of maximize the dimensions. It's the most standardized for the guidelines. Anything sort of below the aorta is inner to inner edge. So that would be the aortic valve annulus, and everything from the sinuses, valsalva, and onwards is leading edge to leading edge and diastole. The LVOT, another source of healthy conversation. So this is measured inner edge to inner edge, and in mid-systole, where the aortic leaflets are open like a goalpost, nice and open. Now, a few options. So the guidelines have typically recommended measuring 3 to 5 millimeters from the annulus, and that would typically be where you measure your pulse wave Doppler for your LVOT measurement for the stroke volume. But in recent years, there is a shift towards measuring at the aortic annulus. So right where the leaflet or the cusps insert, as it's a better measurement for aortic stenosis severity. When you have a bioprosthetic valve, for example, which increasingly common with our TAVI population, this LVOT is actually measured at the base of the prosthetic aortic valve, and we measure from outer to outer edge of the inner stent, and very helpful to document the size and type of the valve for the report. This is an example of an aortic valve, of a ascending aorta that is dilated around 5.7 centimeters. This patient actually had a type A dissection, so very helpful methodology to diagnose. In terms of the measurements, these are the reference ranges. In practice, generally, when we see 40 millimeters and above, we start considering it significant. But of course, at the extremes of body surface area and based on sex, we can make a judgment call. The Zoom mitral valve is as is. We see the leaflets, the annulus. We get a 2D and a color clip. The top leaflet is the anterior leaflet. The bottom is the posterior. Again, some common pathology. Here we have some nice mitral valve prolapse where we have displacement of the mitral valve leaflets around 2 millimeters or beyond the mitral annulus into the left atrium. You can really only diagnose mitral valve prolapse in a parasternal long axis and potentially in apical 3 chamber, but not on an apical 4 or 2. And on the right, we see a very interesting example of a flail mitral leaflet. Standard M mode we will apply for the aortic, mitral, and ventricular level. In the aortic level, we like to see that nice box with the aortic leaflets opening and closing. And same thing for the mitral valve. We want to see the leaflets present. This is an example of systolic anterior motion of the mitral valve that was seen in a hypertrophic cardiomyopathy patient. And we can see that the mitral leaflet is eliciting some sound. The right ventricular outflow tract. So now we're tilting our transducer anteriorly and we're rotating slightly clockwise. We're obtaining the standard images. We see that we have the RVOT on the top, the pulmonary valve, and the pulmonary artery present. Then to get the RV inflow view, we're going to tilt the transducer inferior-medially and rotate a little bit. And we're going to obtain the standard images. Now, depending on what we see, that will determine what leaflets we actually may appreciate. So on the right, typically, it's more or less always going to be our anterior leaflet of the tricuspid valve. If you see the interventricular septum, the coronary sinus, you're most likely looking at the septal leaflet. And the eustachian valve, coronary sinus can also be seen in these views. Now we're moving on to our parasternal short axis where we got our great vessels. And that's when we rotate 90 degrees clockwise. And we can move up a little bit if needed. And we interrogate each valve with either the exercise or the zoom function. This is the gross anatomy equivalent of what we see. So we have a nice aortic valve in the middle. We have the tricuspid on the left and our pulmonic valve on the right. Now we can appreciate our right atrium down below and other subsequent structures. And this just corroborates much of that. And the only other comment to make is that you can actually apply color to the interatrial septum as well down here below to interrogate for a shunt, but just not to be tripped up by normal inflow that might come from the IVC, SVC, or a tricuspid regurgitation in case you see colored turbulence. Now we're zooming into our aortic valve. We're getting a 2D and a color clip. In terms of the anatomy, Typically, the right is on the top, the left is on the left, and the non-coronary cusp is on the left side. And someone once said that it's right lies north as one abbreviation to try to remember. And basically, the left main coronary artery is around 3 to 5 o'clock, and the right main coronary artery is around 11 o'clock. And that helps influence the naming of the leaflets. Here we have some interesting configurations that we want to be on the lookout for. We have a unicuspid valve shown here, bicuspid valve, the usual tricuspid, and here, very rare four-leaf clover, a quadricuspid valve that we may appreciate. In terms of the timing of when to diagnose and look at these things, it's best to look at the bicuspid in systole, as you will see only the two commissures, because it may appear trileaflet in diastole due to a RAF phase. So always best to assess configuration in systole. Now we have moved on to our focused pulmonic valve view, where we've tilted a bit more superiorly. We try to open up the bifurcation of the pulmonary artery. Standard views, you get your right and left at the bottom. And now we've moved on to our focus view of the tricuspid valve, where we're looking at the anatomy and the motion of the leaflets. On the right-hand side, you will see the septal leaflet, and on the left, you may see either the anterior or the posterior. Can't always tell. This is an example of severe tricuspid regurgitation in a patient who had some substance use and carditis. We can see some torrential tricuspid regurgitation here. We often, very important, CW Doppler we obtain here, and we try to get nice, dense jets as much as we can. And this helps derive our RVSP, which is obviously helpful for, clinically. Now we are tilting and we're looking at the mitral valve to show the excursion of both the anterior and the posterior leaflets. In terms of the anatomy, we can see on the right, we are looking at our lateral wall. And that's actually, when it comes to the anatomy of the mitral valve, that is where the first 1 to 3 begins. So we have our anterior A1, 2, 3 on the top, and then the posterior 1, 2, 3 on the bottom. So the right being the lateral wall. This is an example of a patient that had rheumatic mitral stenosis, some thickening of that mitral valve seen very notably. In terms of the papillary muscle, we then tilt a bit more inferiorly. The LV cavity should appear as circular as possible, and we should really demonstrate the myocardial thickening. If you're a bit more elliptical, it suggests an oblique intercept angle. In terms of the gross anatomy equivalent, likewise, we can see here this hardy muscle. Then we have the papillary muscle, the posterior medial one here, another papillary muscle in there, and then the right ventricle on the right. And this is a very good view to assess regional wall motion abnormalities, given the optimal endocardial definition that's often obtained with this sequence. Then we start scanning towards the apex, and we really shouldn't be seeing much of the right ventricle at this point as we're tilting inferiorly. Now we are on the apical four-chamber. So the patient is in a steep lateral decupitous position. The probe should be applied to the point of maximal impulse, usually along the mid-axillary line in the fifth intercostal space. We try to avoid foreshortening, as the view should really be 2/3 left ventricle and 1/3 left atrium. The apex should taper and should be nice and long and not rounded, admittingly harder in practice a lot of the times. This is the Mayo Clinic orientation of the anatomical equivalent of the left ventricle. So please reverse it in your mind if you're outside the Mayo Clinic. So for us here at Toronto, this would be your left atrium, your mitral leaflet. You get these beautiful papillary muscles. Obviously, you're in the left ventricle of this interventricular septum here. You have the right ventricle, a lot of trabeculation, tricuspid valve, and then you see the right atrium with a lot of the pectinate muscles there, and then your IVC comes in. An interesting phenomenon when we do our apical four-chamber is that you actually often get a loss of signal in the mid-segment of the atrial septum. It's considered artifact, and that's because you have a thin fossa ovalis that's often parallel to the ultrasound beam, so it can cause echo dropout. So not necessarily a hole of sorts, just normal echo dropout. And sometimes you can really look for lipomatous hypertrophy as well, that's seen with age here. We've now moved on to obtain a zoomed left ventricle image. We are optimizing the depth setting to go just beyond the annular plane. If the left ventricle is spherical, the image can be a little bit foreshortened. Now, probably the most juicy piece of information we all try to obtain is the left ventricular ejection fraction. So the current standard is to use the methods biplane standard of discs, so that's the gold standard, and it's derived from tracing the volumes in an apical 4 and 2 chamber view. We trace between the compacted myocardium of the L and the LV cavity. And so we do this at the end of diastole and the end of systole. It's important to note that any prominent trabeculation, papillary muscles, they are part of the LV cavity. So we do not trace around them, but we rather trace right through them and include them in the volume of the LV. Sometimes this can be difficult in non-contrast images to appreciate, so we end up just qualitatively assessing the left ventricular ejection fraction. But that's why I think as part of increased quality of echocardiogram labs, there's a movement towards using ultrasound enhancing agents more routinely, as is done locally, for example, to obtain left ventricular ejection fraction. So when we see that 2 or more contiguous endocardial segments are not well seen, we use these UAEs, or definity contrast, for example. Oftentimes the volumes you obtain with the use of these agents are slightly larger, but the LVEF is deemed to be more reproducible. It correlates better with other cardiac modalities like cardiac MRI, for example. There are no partition cutoffs for severity per se. In terms of the volume, it's simply sort of abnormal is greater than 98 milliliters per meter squared for men and 83 for women. Although, as we've obtained more data in the last decade, here through the grapevine, these values are soon to be updated, so stay tuned. In terms of the wall segments, this is a nice diagram. There's another one in the guidelines, but just to help appreciate which walls we're looking at when we're seeing the left ventricle. So really, in the apical 4, we have more so our inferoseptal wall, the apex, and then sort of the lateral and anterolateral wall. When we're looking at a 2-chamber, we are really looking at the inferior part of the heart and then the anterior wall of the heart. And this is sort of from the parasternal long axis, as we alluded to earlier. It's the inferolateral that's on the bottom, if you imagine this image turned 90 degrees, and the anteroseptal part of the heart. And these are the equivalents in the parasternal short axis view. So really, when we're commenting on wall segments, abnormalities, we're really looking from the base to the mid to the apical part of the heart. Wall motion scoring exists in the literature. It's used by some labs as well. But really here, what's important to highlight is really the definition. So if you have normal wall motion, you have appropriate thickening. If you have a hypokinetic wall segment, you have some reduced thickening. If you have an akinetic segment, basically absent or negligible thickening. And if it's a dyskinetic segment, there will be some thinning or stretching. And this actually includes an aneurysmal segment if present. In terms of the left ventricular size, from the 2015 tumor quantification guidelines, this is often the values we're looking for when we're trying to deem if something is moderately or severely dilated, and again, indexed by body surface area and per gender. When looking at the left atrium next, ideally we'd like to get a focused view of the left atrium. Similarly, standard is to now use sort of the biplane summation of discs method. There are others, such as the length area method, but locally we like to use the volume method. We are timing at end systole, where the left atrium is at its sort of maximal diameter. We're looking at the base of the left atrium, specifically that we connect with the two lines, and we're tracing the inner border of the left atrium. We do not include the area under the mitral valve annulus, neither the pulmonary veins or the left atrial appendage. The cutoff criteria has some partition values in the current guidelines. So anything normal is basically less than 34, and 35 and above is considered enlarged, 48 and above severely enlarged. And often this reflects the burden of left ventricular pressure, volume loading, and it's probably the best left atrial parameter that predicts cardiovascular outcomes. And next, we will obtain a pulse wave Doppler across our mitral valve, and this will help obtain inflow values, and this is helpful for diastolic function. We will then apply some tissue Doppler imaging. We'll use a pulse wave Doppler along the septal and the lateral wall, and we like to measure basically where these points are marked. It helps reflect the accurate timing. Then you will see these charts commonly across labs across, I'm sure, the world, and this helps grade diastolic dysfunction. This is a talk worthy of its own, as some of my colleagues have previously done. And basically, we review these parameters and help make a judgment call if diastolic dysfunction is present or not. And most of these values we've already obtained. For example, the left volume index, the peak velocity of our tricuspid regurgitation, and then our tissue Doppler information. Next, we have moved on to the right ventricle. So we're going to rotate the transducer a little bit, and we try to maximize our right ventricular area. We try to keep the apex in the center and adjust our depth and zoom appropriately. And then what we can appreciate is that the right ventricle is quite a complex crescent-shaped part of the heart that has a complex contraction pattern. And then so assessing it quantitatively is an ongoing area of research in the literature. Nonetheless, for now, we use a combination of methods. One is the old standard qualitative assessment. So when we just look visually at the heart, the right ventricle, if we see that it's smaller than 2/3 of the left ventricle, we may call it mildly dilated. If we see that it's sharing the apex with the left ventricle, we will call it moderate. And if it's larger than the left ventricle and apex forming, we will call it severe right ventricular dilation. To corroborate with some numbers, we calculate or measure the RVD1, that is the basal or the RV minor diameter. Anything greater than 41 millimeters is considered dilated. Similarly, there's an RVD2 or the RV major or mid diameter measurement. Anything greater than 45 millimeters is considered abnormal. Then we calculate our TAPC. So this reflects the longitudinal systolic right ventricular performance. Admittingly, it's looking more so at the base of the right ventricle. And really, we shoot an M mode parallel to the lateral tricuspid valve annulus. If you decrease the gain, sometimes you can get a bit more of a focused image. And zoomed in is actually what's recommended by the guidelines. And really, we measure the distance from the minimum to the maximum excursion. Anything less than 17 millimeters considered abnormal. And there are variations. Some people go along the slope, but the guidelines will measure from top to bottom of the height. Then we obtain the pulsed wave Doppler S prime wave. So this is the peak systolic velocity of the tricuspid annulus, reflective of the basal right ventricular function. We're shooting down a pulse wave Doppler using the tissue Doppler settings on the machine. The cursor is aligned with the right ventricular free wall. Anything less than 9.5 centimeters per second is considered abnormal. In terms of the right ventricle itself, very similar to the left ventricle, it's from the fourth chamber. We're looking at end systole. We're tracing along the inner borders. We're using the symptoms volume method, that is the increasingly recommended standard. In terms of the reference ranges, the guidelines will only provide, basically, they've provided a normal range. So for men, pretty much anything 33 and above is considered enlarged, and for women, 28 and above would be abnormal. Now, moving on to our 5-chamber aortic valve, we have tilted the beam a bit more anteriorly. We're obtaining the 2D color and the Doppler sequences, and we can see that we've really opened up the aortic valve nicely. This is an example of the of severe aortic stenosis, where we've obtained a CW tracing. It's very dense jet that's formed, and the mean gradient, for example, in this patient was around 73, and you would obtain the PW Doppler similarly, and this helps assess the aortic stenosis. In the 2-chamber, we've now rotated 60 degrees counterclockwise, and we obtain the full sector with both the left ventricle and the left atrium, and then a focus clip on the left ventricle. To obtain the apical 3-chamber, we rotate 60 degrees counterclockwise from the aortic 2-chamber, and we likewise obtain the full sector and then another focused view on the left ventricle. And now for our subcostal view, we see that our patient is in the supine position. The transducer is at the subxiphoid process. The index markers around the 3 o'clock marker. We ask the patient to bend the knee, take a breath in, depending on what image quality we get. In this view, we like to apply the color Doppler both over the interventricular septum to assess for any shunts, and then as well over the interatrial septum to look for shunts. And we often lower the color scale due to the low flow state seen in the atria. Again, Mayo Clinic orientation, but helpful nonetheless, in that we are typically seeing our atria that are kind of closer to the lower part of the image, and then the right ventricle, ventricular septum, and our left ventricle. Our subcostal views are helpful in assessing the right ventricular wall thickness, helpful in a myriad of cardiac pathologies. It's measured generally at the end of diastole, and we try to avoid epicardial fat and coarse trabeculations, and anything that's greater than 5 millimeters is considered very helpful to assess pericardial effusions in this view as well as peristernal short axis, peristernal long axis. Basically, effusions can be assessed throughout the whole study, but oftentimes this is the quick, easy one that you can obtain in a sick patient. And in terms of what we quantify or qualify as a pericardial effusion, if you see it only in systole, basically you consider it trivial, may not even call it on a report. If it's a small pericardial effusion, you see it both in systole and diastole, but it's less than 10 milliliters. If it's 10 to 20 milliliters, we call it a moderate pericardial effusion. It's considered large if it's 21 to 25 millimeters, and very large if greater than 25 millimeters. Next, we acquire our IBC, very helpful as well for guiding a lot of clinical treatment. We rotate the transducer counterclockwise, and we try to elongate it as much as possible. And oftentimes it's at its maximal dimension at the end of expiration. And we like to perform the sniff test. So you ask the patient to take a sniff in to assess the collapsibility. And this sniff basically elicits a brief and sudden emptying of blood into the from the IBC to the RA. So helps you kind of really assess if it's dilated or not. And oftentimes shooting an MO down can help just visualize that very nicely as well. So where you actually measured is roughly 1 to 2 centimeters from where it joins with the right atrium. You try to make sure you're perpendicular to the IVC when measuring it as well. We measure at the maximum diameter and expiration from inner to inner edge, and we use the collapsibility index to estimate the central venous pressure. So if the pressure, if the IVC is collapsible, it's less than 2.1 centimeters, the right atrial pressure is 3. If it's not collapsible, if it's dilated greater than 2.1 centimeters, RA pressure is 15. Anything Any combination of either is considered an RAP of 8 in the middle. Obviously, if a patient's on a ventilator, the IVC assessment is really not valid in that sense because of the positive pressure they receive. And healthy athletes can also actually have a dilated IVC just physiologically from their exercise. We like to obtain a hepatic view in the subcostal, and that you just angle a bit more rightward, you rock a bit more superiorly, and this helps, particularly in the assessment of tricuspid regurgitation. This is, for example, a still image of the flow reversal from a pulse wave Doppler in a patient with severe tricuspid regurgitation, and you can appreciate the systolic reversal that's coming towards the probe here, indicative of severe valvular pathology. We then move on to our suprasternal view. We place the probe on the suprasternal notch, index roughly around 12 o'clock. We rotate the transducer a little bit to the left shoulder, and we really try to cut in the plane through the right nipple and top of the left scapula. In terms of what we see, we have a beautiful ascending aorta there. We have the different branches coming off of the ascending aorta. Oftentimes you will see this little circular vessel, and that's the right pulmonary artery, and it depends how you're angled. Sometimes it may be a bit more elongated, but we try to get a bit more circular. It shows you a bit more on axis. And obviously a very useful view for both assessing the width of the aortic arch to assess for aortic regurgitation in case you have retrograde flow. As seen here on the left, this is a patient we saw that had severe aortic regurgitation with the hollow diastolic flow reversal. And oftentimes you can assess for any intimal flaps as well and or occultation. So that is sort of the basic image acquisition. Oftentimes, if you have any more valvular disease, of course, quantified, and there's a lot of add-ons. This is just a mention of the CSC, Canadian Society of Echocardiography calculator, that is very helpful in both assessing further ventricular masses and valve equations that become very helpful when there's a lot of pathology present. Just a note to say that this is the core, and there's so much more we do on a day-to-day basis when doing the echocardiogram. If there's any valvular disease, we really focus in on that. We quantify it with our different Dopplers and different views. If there's pericardial disease, that's a whole intense protocol, mitral inflow, tricuspid inflow, etc., to look for constriction, restriction, tamponade. Ultrasound enhancing agents are becoming more common, especially for LVEF, left ventricular size, regional wall motion abnormalities, as well as thrombus assessment. Agitated saline contrast is very helpful for assessment of shunts, particularly right to left. Global longitudinal strain is really emerging as well for both global function, RA strain, and cardio-oncology patients, and 3D echo for LVEF and volume. And so just some parting thoughts, in that TTE is very readily available, obviously provides a wealth of diagnostic information and prognostic data for cardiac conditions. When the views and diagnoses are non-diagnostic or diagnostic of significant pathology, oftentimes we can recommend another imaging modality, either transesophageal echocardiogram, cardiac MRI, or CT. So, if you can't see good things, everything you need to, not to worry. There's often another modality that can help us out. So just a thanks to Drs. Howard Leonpoint and Chiming Chow for the review of the content of the slides and provision of some case examples. Drs. Kim Conley, Jeremy Edwards, and Geraldine Ong for their brilliant excellence as well and teaching in the last month. And my senior colleagues, Sean Kai, Ashwin Padiath, Flora Huang, Yazid Almaki, and Carol Graham, who have been just wonderful senior fellows and providing you with lots of pearls of wisdom for this talk as well as all these stenographers who have made this month very enjoyable and been very patient. So thank you. Yeah.